and moderator. All chairperson, moderators, and opening remarks, and Dr. Roma Sinha, everybody is a co-host. They can mute and unmute themselves. And most of the time when it is not their turn, they can keep themselves muted. And after that, I mean, once it is their turn to present or speak, then they can unmute themselves.
Fine. I think there are people who will keep joining, so I guess
Yeah. I mean, still we have another 1 or 2 minutes. So you can meantime request Nikhil to please. Dr. Nikhil, can you hear?
I can. Good afternoon.
Yeah, hi. Could you share your screen?
Welcome.
Who is this guy?
And thank you from joining from France. I mean, it's so
Thank you.
terrible.
We started early, so I've just literally got back. I'll just share the screen, please, Dr. San. Good afternoon, Dr. Bhandari. So this will be my talk. I hope you can see the slides.
Yes, we can see very nicely. Great.
Lovely, perfect. I'll stop sharing. Thank you very much. Thank you, Arun.
Thank you. Yes, Dr. Roma, how are you?
I'm very well, thank you. Good evening to everybody.
Thank you very much. Good evening to everybody, and then welcome that you joined. Thank you very much.
Yeah, it's a pleasure and a privilege for me. Thank you.
Yeah, you are part of this.
Of course.
And because you are not having any presentation to make, so we are not texting, we can see you and we can hear you. Audio is clear and picture is bright. So that's fine.
Thank you. I'm waiting forward for the presentations.
Yeah. I think Dr. Arun.
Yeah.
Now it is time. You can just start, please.
I think so. Yeah.
Okay, great. So, great, warm welcome to all the participants, the faculty, delegates who have joined us across the world for this meeting series which we are starting. And this series would be on robotics. Today is the first day, and this is a joint program between GAPIO and ARIS. GAPIO, as everyone knows, is the Global Association of Physicians of Indian Origin. It's got thousands and thousands of members across over 50 countries. And ARIS is the Association of Robotic and Innovative Surgeons. So the combined effort, we start our first series, and for which I would like to welcome first Dr. Nand Kumar Jairam. Dr. Jairam has had a 4-decade career as a surgeon in minimal access surgery, and we all know him. He's also the vice president of the GAPIO organization. He is former chairman and CEO of Columbia Asia Group of Hospitals. Currently, he is an independent healthcare advisor. So welcome, Dr. Jairam. And also I would like to welcome at this moment, Dr. Subhash Khanna, who's a dear friend and also the president of the Association of Robotic and Innovative Surgeons. He is the chief of Department of Minimal Access GI and Robotic Surgery at Swagat Super Speciality Surgical Institute, Guwahati. He's a visiting professor at GSL Medical College, Rajamundry. He's received numerous prestigious awards and has been a pioneer in Northeast India. In fact, I don't think there is a surgeon matching his caliber, expertise, entrepreneurship, and he is a role model for many surgeons in this country. So welcome, Subhash. He's also the BC Roy National Awardee in 2017. So with that, I would like to request Dr. Nand Kumar Jairam to say a few words and get the meeting started. Over to you, Dr. Jairam.
Thank you, Dr. Prasad, and good evening, good morning, and good afternoon, ladies and gentlemen. It's a pleasure to be seated here and listen to this session, not only because I'm a surgeon, but also because of the activity that GAPIO has initiated and continues to kind of deliver through the leadership of Dr. Anupam Sibal and Dr. Tandon. Yes, I was introduced as a surgeon of 4 decades. When I started, there was no minimally invasive surgery, so there was definitely no question that I was a surgeon who used his hands to perform surgery for a good part of my career. Watching the innovations that happen today tells me that we have come a long distance from the time of open surgery. Minimally invasive surgery itself was a significant advance, and now robotic surgery, which I watched and understood, is indeed an innovation par excellence. I would be pleased to listen to the stalwarts in this field, and I would be most happy to now pass on the mic to Professor Subhash Khanna, who's already been introduced, so I won't labor on that. Over to you, Professor Subhash.
Thank you, Dr. Kumar Jairam, and thank you very much. In GAPIO. I'm Professor Subhash Khanna, president of a new association, which is the first of its kind born in India, Association of Robotic and Innovative Surgeons, born in India, but with a global look. I know we have over 1.5 million physicians of Indian origin all over the globe, and we are very delighted to be collaborating with I'm glad that Dr. Arun Prasad has taken up this initiative. So, well, we had been doing robotic surgery for about two decades since 2000, but then there was no concentrated effort on the part of robotic and innovative surgeons coming up with various innovations to come up with an association which would look at the future of our surgeons, their training, their credentialing, bringing the guide to include robotic and all newer innovations in our curriculum. So we, 7 of us, the founders, I wish I could make my presentation also, join together to start this association. And this association has over 76 members right now, but we will soon be in hundreds and maybe in thousands the way robotic surgery is growing for the general association. So this association is registered. We are doing good work, and soon we are going to announce our another program through the association. We are doing another program with the Royal College of Surgeons, Edinburgh, this 11th of July evening, 7 p.m. BST, and Indian time will be around 11 o'clock in the night. I will request all of you to join, because now we are collaborated. You are also a part of. We are part of. Also welcome you all later to join us for the World Congress, because India is doing the first World Congress of Endoscopic Surgeons in the last part of 2024. That's a little bit about the work being done here. I thank each one of you, and I wish this program, the first program, a great success. And I know we are starting with the basics, and there's many things to come up. All the best to all the speakers, and a very good evening and good morning to all the delegates once again. Dr. Arun Prasad, can you take over if you are there?
Arun,
Doctor,
you're on mute.
Unmute yourself. Arun, unmute yourself.
unmute yourself, please.
Thank you, Subhash, and thank you, Dr. Nand Kumar. And now I would like to welcome Dr. Ruma Sinha, who is going to be the chairperson of today's program. And Dr. Ruma Sinha, after having 26 years of experience in laparoscopy, was a pioneer in 2012 for robotic gynae surgery. She has extensive experience in treating endometriosis and fibroid. She is currently senior surgeon at Apollo Hospitals in Hyderabad and also an associate professor in Sydney. She is the founder, president of Association of Gynecological Robotic Surgeons, editorial board of many journals, and she has been conferred with numerous awards and of Apollo Hospitals, Nari of the Decade, Excellent Medicine by FICCI, and so on. So welcome, Dr. Ruma Sinha. It's a great honor to have you here to chair today's program. Over to you.
Thank you, Arun. Thank you for your kind words. It's my privilege and pleasure, as I said, to be part of this momentous evening, and obviously the inaugural meeting of ERIS, as I'm a member there too. So it's really good to see Dr. Subhash and everybody here. So let me get down with the brushstrokes and the program, and I would like to introduce the first speaker today, Professor Bhandari. Any word that I say will be actually quite less to what I would like to say. He's a inspiration, a mentor, and he has been with me for all these years that I've been trying to do robotic surgery. So that's how I would like to introduce him with. However, he is a postgraduate and graduate from the CMC Vellore way back in 1975. But the great credit to him is to do an MBA from the University of Michigan in 2010. He is at present director of the Robotic Surgery Education and Research Program at Verticity Foundation, as well as the chief executive officer of the same foundation, which helps across the world to improve and take the robotic surgery academic program forward. He is also the recipient of BC Roy Award, as well as a Padma Shri in the year 2000. He has many, many publications. Sir has been instrumental and a guide for so many research projects that I may not be able to even mention most of them. But the most interesting part that I have been actually learning from his short introduction is that there is an exhibit in the Smithsonian Museum of American History, which gives information about Sir, that he has been awarded O1 as a very, very special visa for extraordinary brilliant category of EB1, as one of the only 2 doctors in the history of immigration of USA as brilliant physicians that have been granted this visa. So, sir, you have, as I said, welcome to this meeting, and we are waiting to hear your presentation. Thank you so much. Over to Dr. Bhandari.
Can you see my screen?
Yes, sir, I can.
At the outset, Dr. Nand Kumar Jairam, Vice President of JPO, Professor Subhash Khanna, my dear friend Anupam,
There's no one in your contact
and
Ruma
Sinha and Arun. Arun, thank you very much for roping me in, and it's entirely my pleasure to present what I have to say about evolution of robotic surgery. The evolution of robotic surgery in India, I would like to deal with it in 2 components. The period between 2002 to 2009. This is a period which coincides with the beginning of robotic surgery and for which all of us Indians should be proud of. that is the time when Dr. Mani Menon at the Henry Ford Hospital, where I have the privilege of working with him for 17 years. Since last year, he has left for New York. Uh, that is the time we started having robotic surgery. And during this period, 6 robots were present in India, and in total they had done 400 procedure. The credit goes to none other than Naresh Trehan, who thought of and fought with the company to get the robot, because company was not in that shape to supply a robot to India, and got the first robot, which he performed surgery on December 23rd, 2002 at the Escort Hospital. Subsequently, uh, 3 other robots were bought by the cardiac surgeons, and Venugopal at All India Institute of Medical Sciences bought the robot. And there was a lot of negative press, which I would not like to use it to the credit of these stalwarts who face such a criticism in trying to buy a capital heavy equipment in those years, which really had not even company faltered to find out, because they marketed this robot and got the FDA clearance for cardiac surgery, which did not really ultimately pick up. 2010 till date, Vattikuti Foundation joined the journey, and what I gather the statistics, which is 106 robots are there and about 10,000 procedures are being done. And we are not talking of only Da Vinci. We catalyzed the presence of robotic surgery program in joint replacement also. Now, what is Vattikuti Foundation's very simple objective we have is we are focused on patient outcomes. And for that, we want to leverage technological innovations, but technological innovations, because my friend often uses this term, Alex Motry, a fool with a tool is always already a fool. So that kind of thing, until there is a surgeon education which has a very different breed of surgeons who are innovative, who are exploratory, yet they are safe to the patients. Our journey started with, in 2009, we started talking to Dr. Trehan because, and we had planned for 4 institutions where we managed to finance the robots and start the program. And it was months-long conversation with the surgeons. And then I happened to meet chairman, because it's very important to acknowledge few people who really gave push to this program. And I met him in the morning at 11 o'clock, and then by 8 o'clock, he fixed up a dinner meeting with about 100 consultants from Chennai. And next morning, he took a decision to have 4 robotic programs at Chennai, Hyderabad, Apollo Delhi, and that was the tipping point, and Apollo Clinical Kolkata. Immediately we formed a strategy and we had a road show, because we really wanted to whitewash the image that this robot is a white elephant. It's only for lima harvesting. So we decided to do a road show at 6 places where the robots were installed, and we brought a faculty of about 15 international mentors, 20 master classes we did, and that was the beginning of the whole program. Thereafter, many of you like Ruma and Arun, they were participants right from beginning. We did 2 meetings entirely supported by foundation per year, and we did till COVID, we did 11 meetings, and we had a gathering of about 250 people participating in these meetings. We used to give scholarships, and we did master classes depending upon the need of the hour with the international mentors. We did 2 global robotic meetings, because it's not a presentation to show that what foundation has done, but according to my assessment, these were the events which triggered a wider interest in the surgeon that this technology is going to stay. And it is futile to keep blaming the cost involved with the robotic surgery as the only excuse to stop this conversation. We have had 60 mentors in these two meetings, 12 and 15. They were very largely attended meetings, and we had interactive live operative workshop. We, you would be happy to know that we have two Mako robotic programs where foundation played a key role. And one of the program at Sunshine is really picked up well. They have two robots, and really it's another thing which really excited surgeon was the surgical innovation. And I'll give you one example of how foundation leverage its global network of doing the cadaveric work with Ohio State University. And we have people from national, Woo Jeong is from Korea, and Ravi Broad from England, and Dr. Menon. And we really developed the procedure of robotic renal transplant, which was one of the innovations funded by the foundation. And thereafter, this was done according to ethical clearances in two centers in India, wherein we did 7 transplants each. We analyzed the result. We used the ideal technique from Oxford to innovate the surgical procedures and then published it. And what is exciting is that there were no takers when we wanted to do this program in the United States, but then we re-exported this procedure back to Henry Ford, which has done close to 100. And now there are foundation supported about 20 centers across the globe where they are doing, and the Europe is a very big force for robotic kidney transplant. Smithsonian, I'll just make some correction, is not a recognition for me alone. It is Smithsonian Museum is a recognition for the foundation. And they recognize the history of immigration in United States and look for stories in 500 years of immigration, and only 2 doctors emerge, Dr. Menon and myself. And there is an exhibit which has said Dr. Menon was recognizing this procedure to robotic surgery to the world, and they wanted to prove that not only immigration is a loss to native country, people do take it back to their own country. And that's thing. Now we run regular fellowship programs, which are very much in demand. Our alums are testimony. We have 40 people. They are heads of department. They are outside the country. And our objective is to make sure that after 1 year of fellowship of handpicked people, they are able to really go and perform independent robotic surgery. And not only they are technicians, but they develop equally good academic temper. As everybody was forced to do these webinars, we had pandemic effect, and now we have gone on to 72 countries participate in our teaching programs, and we have associated with international bodies or subsections like who conduct these webinars, because we have a very wide network of the people. Now, I would say robotic surgery is on auto mode in India. It is growing, and so happy to see that there is a robot made in India completely. And that's the day we are very, very looking forward to, when every district hospital would have a low-cost robot. Means technology is going to stay, and the benefit would percolate down to the lowest strata of the society or underprivileged. We run best practices competition, and this is one of the activities foundation do, is to really invite videos from all over the world. We are expecting hundreds of entries to decide on which one would be the best. And so far, India has really done well. This is the only first year we have taken it to international level. Otherwise, we have had resection, liver resections, and esophagectomies, and all those procedures which are esoteric for robotics even now. Thank you very much for and I'll be very happy to answer your questions. Thank you.
Thank you, Professor Bhandari, for reliving those moments of starting of robotic surgery in India. And very truly, people like Arun and myself have been almost from the beginning since it started in India. So that feels good. I think we will be having the Q&A session in the end. Arun, am I correct in that?
That's right. Yeah.
So we will proceed with the next talk, and for that I invite Dr. Arun Prasad to join us for his talk on setting up the robotic surgery program. Dr. Arun is a senior surgeon from Apollo Hospital in the Prest, and he has about 36 years of surgical experience there. He has experience of performing more than 10,000 laparoscopic surgery, almost 6,000 laparoscopic cholecystectomies, and over 500 robotic surgeries. He has the privilege of also doing world's numerous first cases of robotic, laparoscopic, thoracic, and also multiple different types of surgeries. He is the former president of the Obesity Society, and he's at present the vice president of ARIS, that is the Association of Robotic and Innovative Surgeons. He's the editor of the Journal of GEMAS, very popular journal. I send my articles there too. And so he's published over 55 papers. I invite Dr. Arun Prasad to deliver his lecture.
Thank you, Ruma, for those kind words. And it was indeed a privilege and nostalgic memory sharing presentation by Dr. Bhandari, who has been a single-handed force behind the Indian robotic surgery program. So I would like to dedicate my talk to Dr. Bhandari and talk about starting a robotic surgery program. So when we talk about starting a robotic surgery program, the first thing that comes to our mind and to the hospital mind is what is going to be the business model. So it starts with the direct cost, which is the cost of acquiring the robot. And acquiring the robot in Indian terms, if we are talking about the intuitive robot, it's close to about 18 crores right now. Then there are associated costs which are there with acquiring a robot. It's not just the robot, it's the consumables which come with it, the staffing which has to be looked at, the entire gamut which we will just be talking about. Then it requires infrastructural upgradation in your OR when it comes to various small things like the height of the room, the presence of various monitors, the upgradation of the anesthetic equipment also is required because of the longer tubes that are needed and other such extras. We need additional recruitments because you need very specialized nursing staff, OT technicians, people in the IT department who can help with the program to run successfully. The staff needs to be trained because it's not that the robot arrives and everybody starts doing the surgery. So you need very specialized and focused training. After all this is over, we also would need to do a market survey. So the hospital goes to firstly find out what is the competition. So you could be in a city where you would be acquiring the first robot and you declare that, okay, now this is the first robot. So my friend Subhash, when he acquired a robot in Guwahati, he was having no competition because he was the pioneer of robotic surgery in the Northeast. While when we acquire a robot in Delhi NCR, there are already about 10 to 15 robotic centers across both in the government and the private sector. So the competition has to be looked at. Then we need to know what is the kind of patient volume. So do I have enough patient volumes already in my hospital, which can be there to utilize the presence of the robot? So if I have enough patients who are coming with, say, prostatic cancer, then yes, I could easily channel these patients through the robotic surgery program. Similarly, what is the incidence of disease? So if we are looking at doing cancer of the stomach robotic surgery and the incidence is very low in this area, then that might not succeed. So incidence of disease, and accordingly, the program has to be modified as to what is a common disease. For example, in North India, we get a lot of obesity patients. So I can run a robotic bariatric program quite easily, while the same bariatric robotic program in, say, some other cities may not work out. The referral pattern is again crucial. So what kind of referral pattern does your hospital have? Does it have satellite clinics? Does it have a pattern where the doctors and uh, general and family practitioners refer patients regularly? The reimbursements which are going to take place once the surgery happens from the surgeon, anesthesiast, various staff, etc., again is a crucial part which helps us decide how to take the program forward. Then there are direct payments, there are indirect payments, then there are payments again for your loans which you might have taken while acquiring the robot. So when it comes to costing, we are talking about the initial costing. Then we also have to talk about the cost of surgery plus extra. So for example, if a laparoscopic bariatric surgery is costing 4 lakhs at my center, the robotic surgery adding another 2 lakhs would lead to a cost of about 6 lakhs, which is going to cover the extras of the consumables plus the extra cost, which again I will talk about the cost model in a while. We also need to make volume-based calculations. So volume-based calculations are quite important, especially for the missed opportunity. Now, if you were to have X number of patients who are coming to you for a particular disease, with robotic surgery, is this number of X going to increase to 2X? Because if it increases to 2X, our second X is something that is being gained by the hospital, which would not have come have we not acquired the robot. So the indirect volume which is acquired is also to be considered. Therefore, we now have what is known as the ABC, which is the activity-based costing when it comes to the management, and the newer one, which is the time-driven ABC. So this basically, the tradition cost which you see on the right is resources and the cost object, just 2 points. Whereas the activity-based costing is based on the product, activity, and resources. For example, the product here is, say, robotic partial nephrectomy. So when we talk about robotic partial nephrectomy, then you need to know what are the costs involved when we are doing this procedure from the robot point of view, from its consumables, the surgeon, the nurses which are going to be utilized, the ward staff. So all the extras have to be added, and that is how an activity-based costing is worked out. So the administration of any of these programs requires record keeping, which these days is digital. Both the videos of the surgery is record kept, the outcomes. It's very important to have complete details from beginning to end, as we would need to at a later date publish and also have a registry and audit of what we are doing robotically if we want to keep our robotic program running. New OR is usually needed because we need space for the robot to be kept, for the console, the anesthesia machines, the height of the OR, etc. Administrative staff have to be there for this. The maintenance is another very crucial point. So you would need somebody exclusively to be involved with the maintenance. Then whenever there is a robot, you would also need help from the marketing department with regards to the website, the patient material, the promotion, and the PR activity that comes with any such program. So when we start the program, initially there are learning curve challenges, because initially the surgeon who has been doing surgery for which takes him an hour or two, suddenly when he starts robotics, he has to first spend a lot of time learning the procedure, unlearning what he has been doing. The same procedure which he's been doing laparoscopically might be taking him 4 hours, and that could be frustrating for a busy surgeon. So those are some of the challenges, and therefore many surgeons who start with robotic give up after a while. Then training again of the assistant is very important, because when the surgeon is at the console, there are many activities that have to be done by the assistant, and the surgeon is totally dependent upon those activities, including some emergency activities that may be required. The anesthetist has to have a separate learning curve, because the access to the head or the endotracheal tube sometimes may not be that easy if the robot is docked towards the head end. They have longer tubes, their monitoring is slightly different. At times, you have, say, a radical prostatectomy going on with the head low, so low that the head can actually pull down the neck and create some kind of an Erb's palsy, or even the congestion of the brain is taking place. So many challenges are there by the anesthetist. Usually in the initial learning curve, the surgeons put very high carbon dioxide pressure, which could be an issue too. The OT staff has to learn how to change instruments, how to bring instruments. They need to learn about the instruments, how they coordinate with a surgeon who is going to be not standing next to them. The replacement, change of instruments is again their prerogative, and at times to use the Allen key in case of a emergency. Maintenance involves data management. Again, with the growth of volume, the maintenance also changes. So does the marketing and the training of this. And finally, upgradation. So we've had a robot for almost 11 years. So we started with an SI, then it has moved on to an X, and now an XI intuitive model. At the same time, we've got other robots coming in, the Versus robot, the Hugo Medtronic robot, the Indian robot SSI. So things keep changing, and all this has to also be kept in mind. So let me just relax the boredom of continuous slides and points by showing you a small video clip. For those who have not been to the robotic theater, this is what the console looks like where I sit for the robotic surgery. And we go on for a personalized setting. Something like once you sit in a Mercedes car, you can set up the exact settings for you. You can also manually change. So the top part is where the surgeon looks inside, and you can see that the console can be moved around. This is where the fingers go in. So you can see the thumb and the middle finger going into those loops. And these loops are going to be then used for the surgery. The foot pedals are there for the right. Again, 2 instruments for cutting coagulation. That's the blue and the yellow pedals. And on the left side, the camera pedal, a clutch, and a switch to switch between various instruments. So this is what the robot actually looks like. So that's a robotic trocar which would be entering the patient's abdomen. And this is the robotic instrument, which the tip, if you see how there is a 360-degree finger movement, which is the 9 degrees of freedom that is humanly impossible to achieve. So the robot is able to give us that kind of freedom and versatility when we are doing dissection and suturing in remote areas and complex surgeries. Now, this is a 250 kg patient who's what we call as a super obese, undergoing a robotic bariatric surgery. With robotic, we can do a single stage gastric bypass. Most places when we used to do laparoscopic, these patients had to have 2 stages of surgery, a sleeve gastrectomy, lose some weight, and then come for the bypass, because a 1-stage visualization and surgery was very tough. This is the robot that is being wheeled in. So the robot is being wheeled in. The arms are all covered with sterile drapes. So robot is brought to the position. That's the robot being raised. And then the arms will move forward. And we will bring the robot to the position that we would like to have it, so that we can do the next step, which is known as docking of the robot. And docking basically means connecting the robotic arms to the trocars which had been placed. The trocars are like the laparoscopic trocars. So this is bariatric surgery in progress. You can see on the screen of the robot as well. Then we also have the advantage of artificial intelligence, which I'll say in a while. So while I'm operating there, when during the surgery we need some kind of staplers device, so this is a robotic stapler, which has kind of artificial intelligence that it can sense the tissue thickness and impedance when the instrument closes, which we will just see in a while. So there you can see the stapler being introduced into the abdomen, and the control is there with the surgeon. So that's the stapler inside the abdomen. And you can see the movement. Now this is going to gauge the thickness. So if you see number 2 written there at the bottom of the screen, so it's clamping, it's gauging, and it's ready to fire, the yellow. And it's firing, it stops for compression because it thinks the tissue is too thick. The firing is completed with the yellow line you can see at the bottom, and then unclamping. So this stapler can move in 360 degrees, which no laparoscopic or open surgery stapler can do. And it gives us that artificial intelligence feel of how thick the tissue is, and it decides how long it will take to compress and fire. This actually leads to a reduced incidence of bleeding and leakage after such kind of surgery. So to summarize, I would like to say starting a robotic program means taking into account many details such as economics, organization, and teaching. The key for success are directly related to the infrastructure supporting the program, coordination of the teamwork, and careful review of outcomes. To create, maintain, and grow a robotic program, it's of utmost importance to build a complete and accurate strategy right from the beginning. The risk-benefit analysis, the business plan, and the leading surgeon are the key factors for success. So while I'm not ready to say that robotics is the future of all surgery, but I definitely that computer aid to current surgical methods is definitely the future. All aspects of life are getting assistance by computers. To similarly, the surgery gets assistance by computers so that we are able to reduce the risk of surgery and deliver better results to our patients. So finally, I would like to say change is inevitable, growth is optional. So when the change came, many surgeons like me joined this wave of robotic surgery, which has changed over the years and is going to change finally for the benefit of all our patients. Thank you very much for hearing. I'll stop the screen sharing and hand it back to Ruma for further.
Thank you, Arun. I think it was a very, very useful talk by giving all the tips that you have probably gathered over years of how to set up a robotic surgery program. And I think because of the different requirements of the hospitals, the cultural differences in patients, and of course, the attitude of surgeons makes a difference where you are actually trying to set up that program. So thank you very much for your insights. And I would now like to invite Dr. Nikhil Vasudev for his next lecture, and he is going to talk about the safety in robotics. And I think that is probably in uppermost mind of most surgeons, as well as sometimes patients and hospital staff, that is robotic surgery safe. Dr. Nikhil Vasudev is a consultant urologist and robotic surgeon, also an associate medical director of cancer services and chair of the robotics steering group at Lister Hospital of the National Health Services Trust, UK. He is also the clinical senior lecturer at the School of Life and Medical Sciences, University of Hertford, UK, and an international professor of our very own AHERF. He completed his super specialization of urology at Royal College of Surgeons of England and also at the Royal College of Surgeons of Edinburgh. Also has a PhD in prostate cancer at the National University of Singapore and fellowship in robotic urology surgery from the Hertford University, as well as the Urological Cancer Center, Lister Hospital. He has a large experience of performing more than 1,100 robotic surgeries, published many papers, almost 216, and is the author of 3 textbooks in uro-oncology. So let me not keep you away from Dr. Nikhil, and please could you take us through with how to do robotic surgery safely. Welcome, Dr. Nikhil. You have to unmute yourself, Dr. Nikhil.
Can you hear me now?
Yes, we can hear you very well.
Well, excellent. Well, good afternoon, ladies and gentlemen, and thank you very much to Capio and Aris for the invite to present on safe robotic surgery. First of all, a couple of acknowledgements: Professor Sibbal, Dr. Tandon, Professor Bandari, and Dr. Sinha. Nice to meet you, and I hope I see you in India when I come across. So, my talk today, and I hope you can see my whole screen, is on safe robotic surgery. And like you said, safe robotic surgery is a very important aspect, because using these multi-million-pound robots in theater, if there's a major catastrophic complication which happens to patients, one always questions the capability of a system. So with you, I'm going to be sharing some of the latest data on the safety of robotic surgery, what I have learned over the past 8 years as a consultant surgeon and also as an international proctor, but also the kind of research we are pursuing right now in a collaborative manner to improve robotic surgery further. The roles that I have are sort of, I'm an international preceptor, both with Cambridge Medical Robots and with Intuitive, but I do a lot of work on low pressure surgery, and I'll just show you how this is really benefiting patients going forward. COVID-19 has had a significant impact on patient referrals throughout the world. In the NHS, we saw a big drop in the number of referrals coming through. But working on the national response team for COVID-19, now what we are seeing is that there is a big surge of number of patients coming across, especially with more advanced disease. And my specialization is prostate, bladder, and renal cancer. This paper is quite a game-changing paper, which we use as a centralization document in NHS England, in which patients tend to bypass non-robotic centers in the UK. And I think this is really stemming the real desire for more and more companies to develop more robotic systems, more and more new robotic systems in the horizon. You look at, every time you go to a new conference, you see a new robot being docked, and congratulations in India too with the indigenous robot being embedded. But I think patient demand is driving a big propensity of more and more centers getting robots. So by and large, if a center doesn't have robot in the UK, it's highly unlikely that they'll be allowed to do cancer surgery. So this is where things are heading. Now, what a patient wants when they're referred across for robotic surgery is we as clinicians want to make sure that they are pre-optimized to the best level that they can pre-surgery. Dr. Prasad's video for very high BMI patient, it's a credit that we've been able to do robotic surgery on such high BMI patients, because probably 10 years ago when the robots were introduced, I still remember discussions about BMI being a significant cutoff. One wants to perform robotic surgery in a very safe, controlled manner. But also what we do a lot of work right now using AI, and I'll show you some data on a trial that I've just published in JAMA on enhanced recovery, because this is the journey that one wants to take when a patient undergoes robotic surgery. This is a paper of mine published with my registrar, Andy Brody, in which we have just published this in the Annals of the Royal College of Surgeons, doing an overview of the number of robotic systems. So currently there are about 6 to 7 main contenders. But going forward in the next 5 to 7 years, I do strongly emphasize that we probably will have another 10 more systems available, especially with single port technology. But the growth now is very stupendous in different areas of anatomy. So a lot of general surgeons are now using the robot compared to what they did. Urology certainly seems to be on the rise, but even my colleagues in gynecology worldwide are using the robot more and more. But now there's a big push on transplant, like Dr. Bandari described, also with thoracic robotics and head and neck robotics. So, the moment we start getting into the ventures of head and neck surgery, vascular surgery, the safety aspect gets even more and more important compared to what it's been with our normal specialties. My center is just located north of London, and we have 2 XI systems, 1 CMR systems with 2 more CMR systems on order. And we do about 450 to 500 complex urological procedures. But in my center, we have head and neck, gynae, colorectal, vascular robotics. So we have essentially 6-day-a-week program using both systems, turning out about 2,000 cases per year. So we have a very high volume center. But being the chair of the robotic committee, our aspects, especially when we introduce new specialties coming through, because there's a lot of gusto and momentum, people want to get onto the robot, is ready to slow them right down and bring them to the table to discuss safety first before we give them accreditation to continue to operate. Now, if you look at the Oxford Dictionary, the word safe by definition is to protect from or not expose to dangerous or risk, reduce harm. And I think this is really, really important, because patient safety is the crux especially when you are introducing a program. And the WHO has also caught on with this. There's a new document, which I have kind of contributed a little bit to, called the Global Patient Safety Action Plan from the WHO from 21 to 2030, in which they have something called the SAFROS project, which is really looking specifically at robotic surgery, the introduction of robotic surgery to take place. This really stems from the WHO checklist that we tend to do in our ORs when we start operating. But essentially, the SAFROS program adds on some additional aspects, such as specific analysis on data and audit data to really reflect, really ensure that the surgeon is trained, the team is trained, the anesthetist is trained, and everyone's ready to go. And the key to establish a very safe protocol in theater, so you're able to replicate what you're learning from. And these protocols obviously need a bit of verification. When we've looked into this and published also, I think an important aspect, especially with robotic surgery, and this is basically on something called a decision tree analysis, we have found that incorporation of adding on hazards, such as where the ports are to be placed, is a big component. So, port positioning, patient positioning has a very, very strong impact on safety of robotic surgery as per the SAFROS protocol. This is just something which I wanted to put out there. So you can see, being an international proctor with CMR, and I've set up quite a few centers in India with them in urology, from being a fairly small company just out of Cambridge where I live, from 2014 now, it's gone right up. So lots of mega investment taking place, 1,000 cases completed in 2020, and now we've completed 5,000 cases. So this is the trajectory of newer companies coming through. So a big momentum with a lot of investment taking place. But at CMR, so I was there in India in February when I met Professor Sibbal. It's the policy is, this is not only unique to CMR, but it's important to really ensure that when robots are coming through, we allow responsible device introduction, we develop training programs which are regulated, and we really believe in team training, because these three aspects are important. And there's a lot of push taking place now for the use of artificial intelligence, for the use of virtual trainers, virtual reality trainers, which are given to surgeons and their teams even before the system arrives, to really warm them up, to make sure they know what to do, so that the learning curves are improved on as time goes on. Again, data in the British Journal of Surgery, looking at the latest with regards to robotic procedures with the learning curves, I think the crux is really down to the fact that the quantitative methods for assessing learning curves need to be improved on. So looking at this, what we did was, in my center, we had Ashwin Tamankar, who is now a consultant at Apollo Navi Mumbai, who trained with us as a part of the Royal College of Surgeons of England Fellowship. And we really wanted to look at learning curve matrix. This is quite unique, because when you start a robotic program with safety, you want to really know how many cases one needs to do to get better, or what's the data looking at. So with robotic prostatectomy, on 2,000 cases that we've done, we were able to pick up that one needs to do about 80 cases to get good, but 300 cases to get really good. So I think this type of data really reinforces the number requirement which takes place. And I'm really proud to say that our paper, which Ashwin was the first co-author on, is used as the standard matrix for training in the UK for urological programs. Now, patient selection is very important. You don't want to really start your program in an unsafe manner, in which you really pick up a very high-risk patient, high BMI patient, patients who've had multiple laparotomies. And I think this is what I tend to do rolled out. And this is papers from JAMA, in which fitness, anesthetic clearance, the anesthetist is a very important factor, BMI and patient consent. And tell the patients, when the programs are starting off, that, look, we are new, we may have to convert to lap or open. So these are conversations which need to happen with patients. We really pride ourselves in my center, having done 3,500 urological procedures, about anesthetic safety protocols, which we published on. We have about 125,000 views on YouTube on protocols that we developed to reduce the risk of any neurovascular injuries when patients are being positioned, like Dr. Prasad has mentioned, head down positions, neuropraxia, etc. And the COVID-19 pandemic certainly caused a lot of controversies, as you're aware, with aerosol. I was proud to be a part of the NHS England team with this, and we developed protocols to improve safety, really, to reduce the risk of leak of gas outside the abdomen, so that there's no risk of this. This is even during the pandemic, where we really carried on operating and offer cancer surgery to patients. And our protocols, I'm proud to highlight, have been really put out in a lot of countries. Now, just a few more points to shoot off with. During the COVID-19 pandemic, looking at our data with low pressure protocols, the risk of COVID-19 was very low. And I think this led on for us to develop more and more research and collaborate and publish with different partners in the UK. We're looking at data on 13 centers at the peak of the pandemic. The rate of COVID was 0.7%. So again, robotic surgery, the aerosol controversy seems to be dying down at the moment. Now, something which I want to just share a couple of my research aspects that I work on. So I operate on very low pressure, and I have a big basic science group. I have 2 postdocs who work with me, in which we evaluate gut cytokines, and looking at patients who have robotic bladder surgery and intracorporeal reconstruction using the staplers that Dr. Prasad described. You know, we are really able to get patients home quicker, and they have less pain, they have less complications at low pressure. And this has led to a recent paper of mine published 2 weeks ago in the Journal of Medical Engineering, in which we have now been able to replicate all the data on low pressure surgery in the laboratory. This is between the United States and my laboratory at the University of Hertfordshire. And we have been able to show that low pressure surgery is safe. You know, we are able to replicate what we are seeing, and we are really rolling the message out with regards to aerosol controversies and so on. What we have seen, this is just a particulate matter capture box that we use, is that within 3 minutes using the correct filters, the entire cavity is cleared out. So there's no real risk of a lot of spin-off of the active virus or even cancer cells taking place intraperitoneally. And I'm happy to share this paper later on. This is just to show you the experiments that we have done. Now, a very important aspect now is artificial intelligence to improve safety. So this is a paper which we've just published in JAMA. This is the world's first randomized controlled trial, which has showed superiority of robotic bladder cancer surgery to open. So it's the only trial in the world which has really showed, you know, that robotic surgery is better than open surgery. But what we picked up with artificial intelligence is even better, you know, with regards to the data which has come out, which has been down to putting trackers on patients to track their fitness post-surgery. And what we have found on fitness graphs is that you can really predict which patients will be sort of coming back with complications such as UTI, pneumonias, etc., based on patient tracking data. And I think this is where we sit with regards to the future of predicting, individualizing, and ensuring robotic surgery is safe going forward. Again, we predicted this with survival data and even with the preoperative anesthetic data, which is quite concrete. So just to conclude off, I think robotic surgery is safe. If it wasn't safe, there would not be such a massive introduction taking place, and many patients will benefit. You know, I've had the pleasure of doing 2 workshops at Apollo Intertrust Delhi, in which all the patients did well, and I hope that this collaboration continues. I think we have a lot of systems on the horizon, multiple manufacturers coming through, but it's important for these manufacturers to come and talk to experts like yourself, like the high volume surgeons, with the anesthetic team, to the nursing teams, because right now there seems to be a lot of replication taking place, and addressing situations such as haptic feedback seems to be on the back burner. So this is important to consider. Like Dr. Prasad mentioned, I totally agree. The operating surgeon is a very important factor, but it's a team approach. The whole team has to be equipped, ready, and trained and work together. And I think artificial intelligence will help capture mega data, will really help us streamline surgical data even further. So with that, I'll conclude, and thank you very much.
Thank you, Dr. Nikhil Vasudevan, for taking us through the different aspects of making surgery safe, and very impressive research that you have been doing at your laboratory. And I believe that the low pressure surgery is really as effective as a high pressure surgery. Being a minimal access surgery for many, many years, doing both laparoscopy and robotic, I think that's what we teach our students as well, when possible. AirSeal is an excellent device to be able to do that. However, it's not very widely available everywhere in all the hospitals in this country. But I think we should anyway work towards reducing the intra-abdominal pressure when we are doing abdominal surgery. So thank you very much for that insight that you gave. I will actually keep this session open now for any question answers. I'm not sure that whether there are any in the chat box.
Sure.
And,
Arun
will join me for that, yes.
Yeah, I've just seen one question, and, you know, further with agreeing with Ruma, and also saying that, you know, in the robotic, we have the advantage of the distension of carbon dioxide, plus the robotic trocars keep the abdomen up. So it's a combination of what we used to use as a lapro lift also. So I can do my bariatric surgery in super obese at 12 to 14 millimeters of mercury, whereas in laparoscopy, it requires 18 to 20. So my anesthetist is very happy with that because that much less of CO2 which is going in. So one question which is there in the chat box is about the safety and what happens if there is an emergency. So in an emergency, as you may or may not have noticed, the armrest which I was using at the console, it has a red button. So when we press that red button, all the arms and all the instruments, they release themselves and we can undock the robot within 10 seconds of pressing that button. If for any reason anything gets stuck, then we have what is known as an Allen key, which has to be applied on top of the robotic arm and you turn it and that also opens up. So as I was mentioning in the setting up, it's very important that your entire team is fully trained as to how to take care of these kind of emergency situations that might occur once in a while. We do see something like that happening maybe once a year, or in the last 10-11 years, I've heard in my hospital about 3 or 4 such occasions. So it's not very common, and we are able to handle that.
Yeah, thank you, Dr. Arun, for that.
Any other questions? Kindly put it in the
chat box, please.
In the chat box, please.
I don't think there is any question in the chat box right now. I would actually take Dr. Nikhil on his discussion about the experiments that he was talking about. So you did mention that you are working with and published papers regarding this low pressure. So other than having the advantage of less low carbon dioxide, the total amount of carbon dioxide as well as the pressure because of the anesthesia implications, do you think there's any other difference as a surgeon that it makes to you?
So, I'll welcome Dr. Bhandari to come in because I speak to him about this very often, Dr. Ruma. So what we did was, you see, the theory in our as surgeons that you rightly mentioned, is that low pressure equates to less distension, less pain. So what we did was we also evaluated gut cytokine levels because I specialize in robotic cystectomy, in which we do the entire operation intracorporally with stapling and so on. And what we found was even more interesting with the cytokine trends. So the hypothesis was that the higher the pressure, the more the gut compression, leading on to ileus postoperatively. So we did a 1-to-1 randomization of 40 patients in each arm. And the cytokine levels, which indicate a degree of subtle gut ischemia, were lower at a lower pressure. And when I say lower at a lower pressure, it was statistically significant. And we published on this too. I think the important aspect of what we have noticed with our low pressure work has been in lines with lesser pain. And when we introduce robotic systems internationally or even in the hospitals, I think there's a big push which takes place to ensure that patients go home a little bit quicker. So just to give you an example, in the NHS, a very important matrix, like Dr. Prasad mentioned with the business case making, is the length of stay. So if our patients who have a robotic prostatectomy do not go home within 24 hours, we are questioned on our data as to why this patient hasn't gone home. And what we notice is that, so I do my robotic prostate at the pressure of 6, which is quite low.
Very low.
It takes a little bit, it takes a bit of getting used to, especially because sometimes, when the pneumo is so low, sometimes the ports can slip out. So it's just getting used to it. And I've done about 350 cases at a pressure of 6 all the time. Our patients, as a matter of fact, now from the 1st of October, we started a day case program for robotic prostate. So they'll probably have the first patient in the morning will head off later on in the evening. That's the degree of confidence that we have. But this is not unique to the surgeon. This is down to the anesthetist too, and the team too. So these were a couple of things. And our basic science paper, which I'm very happy to share with the group and also with Professor Khanna, is the exact same theory that we noticed intraoperatively is what we are seeing in the laboratory too. So it kind of reassures us with AirSeal, because I think AirSeal really helps you maintain that steady pneumoperitoneum instead of a fluctuating pneumoperitoneum. Thank you very much.
Thank you so much for your answer. Arun, do you have any other questions on the board, or would you like to ask anything?
Ruma, could I have a couple of questions from
Yes, sir.
Nikhil?
Yes.
Nikhil, congratulations. As usual, it was very authentic talk and a lot of things to digest and carry home. I have 2 questions. One question is on your learning curve work. I find it very difficult to accept the traditional definition of learning curve for surgical procedures. Give me example. Uh, as per intuitive, I'm quoting a very old work. As per intuitive, 10 cases were good enough for a surgeon to be proficient. And I used to give a definition, yes, patient would be alive at the end of the surgery. But when you go to the functional outcomes of radical prostatectomy or benchmarking nerve sparing with the global best practices data, it needs 300 cases. So wouldn't it be better to split your learning curve work for different specialty, different things? Of course, you have for cystectomy a different learning curve, but for different steps of the procedure, because some steps would be very critical, which would have a accordion effect on the outcomes you're talking about.
Nikhil, would you like to take that?
Yeah, Dr. Brody, thank you very much. And I still remember when I was in Delhi in 2016 with Dr. Bhandari, I asked him this question about learning curve, and he mentioned one thing to me, which is on my desk. It says, learning never stops in robotics. So I hope Dr. Bhandari agrees with me on that. Dr. Bhandari, so what we did was on our data on 2,500 patients is we captured different aspects of what the patient would really benefit from with the functional outcome, the positive surgical margin rates, and so on. So we did a more enhanced curve instead of just using the complication matrix of the 30-day readmission. But I think your suggestion is superb. We can certainly split it up because we have a very modular way of training, similar to what you do at the Padikuti Foundation and similar to what is done at Apollo 2. But I think the bottom line is what we did was we used what the patient would really notice a benefit from. So their continence, their sexual function, and their cancer control. And we sort of matched a figure of 80 when a fellow gets better and better, but at 300, they get even much more improved to the point of independence. So I think you're right. I think the numbers are slightly ambiguous, but this was quite a lot of statistical analysis done at the Royal College by Neil Spencer. And obviously, we're doing more and more work with our different 7 centers which train our fellows. So I hope, I'll certainly share the data with you and take more input.
I offer to join you in this subject because what I have a feeling that more is not merrier. There is a law of diminishing returns. And more you do, I used to do 7 strictures and my quality in a day and my quality went down with the numbers. So what I would like is a very, very interesting area, particularly when so many new systems are coming and I assume every system would have its own learning curve. They cannot use their own data. Now, one question I want you to answer for this August audience, because you are the right person who working on more than one system. Now, today, if I go to the market, how do I choose a robotic system? Of course, cost advantage is one of these things because every robot can be made to work. Can you give some generic, keeping away from the bias of working on CMR and intuitive robot, how should people make a right and logical choice? Because you are answering this question for many of those who ask me this question day in and day out.
Dr. Can I take that?
Yes,
so,
please.
Dr. Bhandari, I think, I have a conflict of interest because I proctor both for intuitive and CMR. But I think it's important to ensure, first of all, that an individual hospital or an individual surgeon has the volume to operate. If someone is doing 1 case a month or 1 case every 6 months, I don't think that's a viable option, not only from the financial point of view, but probably it's not the best service one is delivering to themselves. I think it's really down to comfort. Obviously, the advantage with multiple systems being introduced is that the monopoly with a certain system has had for many years with the costings, and the costings will drop. There's no doubt about it. So, financially, different hospitals will have a different financial model coming forward. There'll be reimbursements and so on taking place. But in the UK, we use a very simple matrix whenever we have a bid for a hospital. If a hospital is not delivering about 150 to 200 cases per year, it is highly unlikely they will have a sustainable volume to maintain robotics. That's number one. But I think what type of system needs to be chosen really depends on surgeon preference, but it has to be not only surgeon, but also finance aspect. These systems, which are now FDA approved, CE marked, are deemed safe enough because there's enough robust checks which happen. But the individual, I think it's really down to an individual hospital, but I think the denominator is that if there's not enough volume of work to maintain and sustain a robotic program, then probably that hospital shouldn't really invest, but there should be more centralization taking place. So that's the way we look at it in the NHS. I hope that answers your question partially, Dr. Bhandari.
Yeah, no, it
Great.
didn't, but it would require an hour of discussion. So maybe you fly to Detroit or I'll join you for a lunch in Paris.
Great. So
Lovely.
thank you very much, Dr. Bhandari, for giving us the honor to hear your talk as the first talk of this series. Thank you, Nikhil, for adjusting your schedule in Paris. I know you would much rather be sitting on top of Eiffel Tower with a glass of champagne, but your sacrifice has been noted. Thank you, Ruma. Thank you, Subhash, for having started the ARIS organization and agreeing to organize this meeting. And I'm sure we are going to have many such more meetings. And I can see Selva Sekar also in the audience. So maybe we could, rope in the Royal College also at our next series. So Ruma, thank you for chairing the session. And
It was mine.
the future series, we are going to be more disease-based so that the people who are attending can get an idea of how a particular disease can be treated better by the robotic technology. So we will have different sessions. We will have more interesting sessions, which would be based on general knowledge. It would not be a technical talk where we will go into the details of the surgery, but more outcome related and how patients are going to benefit. So with those words, I would like to thank Gapio and ARIS again. Dr. Nandkumar had to leave. I would like to thank him and thank you very much for organizing this whole meeting. Thank you, Dr. Tandon and Dr. Sibal, for giving us the opportunity to start this robotic series. I hope you've been satisfied with the first meeting and we look forward to many more. Thank you. With this, we end the session.
Thank you. Good night.
Good night.
Thank you, everyone. Thank you very much. And grateful to Dr. Mahendra Bhandari, Dr. Roma Sinha, Dr. Nikhil, and Dr. Subhash Khanna, Dr. Arun Prasad, and all the, distinguished audience. And we had many prominent personalities like Selva Sekar and Dr. Bhala from UK and Dr. Nanak Pandya from Uganda and Dr. Anju from Australia and so many others. It's difficult to name them, and there were many in the webinar. Thank you very much, and we'll continue. And this was very informative as an initial step. I think we did not know many aspects of, we have heard, but we did not know, what really it goes into doing or starting in robotic surgery at any center. So very good information, which Dr. Mahendra Bhandari has shared, the evolution of the robotic surgery in India. Thank you very much. With these all words, we thank IT, we thank all those who organized, and Dr. Subhash will continue this collaboration.
Thank you very much. Thank you.
Thank you, sir. Thank you very much. Thank you, sir. Good night.
Good night.